of the cirrhosis and portal hypertension. Am I audible and can you see my screen?
Yes, sir.
Okay, right. So this is the second part. We get into the business end of cirrhosis and portal hypertension. We discussed in our last class a fair bit about the theory behind the development of portal hypertension and the development of ascites. So today we are going to take it through to its natural um, sequence of events. So we're going to discuss surgery in cirrhosis and portal hypertension. Now, if you get a short note on surgery in cirrhosis and portal hypertension, usually what we tend to do is discuss non-hepatic surgery in cirrhosis and portal hypertension, because you sometimes end up having to do that, and surgery for cirrhosis and portal hypertension. So the first thing is a liver biopsy. Now, this is an important thing to help diagnose um, what is wrong with a cirrhotic liver, because sometimes you need a biopsy. And it's traditional. You can do a wedge biopsy during other forms of surgery. For example, if you're doing a cholecystectomy, you can do a wedge biopsy, or you could do a true cut deep biopsy. See, the disadvantage of a wedge biopsy is that you have the capsule just hello. I don't know how I just turned myself on mute, but um, if you're going to do a liver biopsy, um, let's say during a cholecystectomy, you take a wedge of liver just beyond the where you dissected the gallbladder. And there the problem is, because it's close to the capsule, you sometimes get artifacts of fibrosis. So the dictum is that you try and take a true cut biopsy uh, whenever you're doing a biopsy of the liver, because you need that whole tissue, the whole tissue from the depth of the liver, as it were. So that sort of gives you a better idea of what is wrong with the liver. So even during open surgery or laparoscopic surgery, you may have to do a true cut biopsy of the liver. So the routes of taking a liver biopsy are as follows. You do a percutaneous, that's a traditional thing when you're not doing surgery. You can do a transjugular, you put a needle down the jugular vein, get into the hepatic vein, and there you do a true cut biopsy from there. So that's also acceptable. And during surgery, either at open or laparoscopic. And as I said, needle biopsy is the way to go, not really a wedge. So if you want to avoid artifacts. Now, what about surgery, surgery in portal hypertension and cirrhosis, non-hepatic surgery? The first stage is assessment. See, I mean, some of these things are asked. I mean, how do you assess a patient who has cirrhosis and who is coming for some other surgery which cannot wait? So of the multivariate assessment, these are the things that have been found to be of the maximum importance. First is the age. If the age is more than 70 years, any years 70 years plus, it adds 3 MELD points to the classification. So if you go in for the evaluation and stratification of liver disease, if you're going in for the child's classification, if you have a child's A, that has a 10% chance of mortality. A B has a 30% chance of mortality. If you have a C, that's an 80%. You can imagine the sort of jump that we are talking about, from 30 to 80% mortality. The MELD gives you a definite better prediction. Every point of increase, this is a very important point to realize, every point in increase leads to a 15% increase in mortality. And if you want to do the median survival for MELD, 0 to 7 is 4.8 years, 8 to 11 gives you 3.4 years. 12 to 15 MELD points give you 1.6 years. But the moment you go beyond 15, see how dramatically it goes down. 60 to 20 is in days, 64 days. 21 to 25, 23 days. And 26 plus is 14 days. Also, in the evaluation of the patient, the ASA classification and class 5 has the strongest predictor for a 7-day mortality. For example, if you have an ASA 4, that adds 5.5 MELD points to the actual scoring. So if you're asked, what are the multivariate, what are the maximal predicting factors for poor results after surgery, it's age, it's the evaluation of by stratification of liver disease. You can use the child score plus, or instead of this child score, you can use a MELD and the ASA classification for evaluation of a patient. Now, obviously, you have a patient coming in for urgent surgery. Now, you need to prepare this patient. What are the things that you do for pre-optimization? Protein energy malnutrition requires low sodium supplements. Remember that this patient has a hypervolemic hypernatremia. So it has to be a low sodium supplement of protein, trace elements, and branch chain amino acids. You need to correct the coagulopathy, where we've been through this. We know what the clotting factors, which are completely dependent on the liver. You have a low vitamin K, you have a thrombocytopenia. You assess for hepatic encephalopathy with protein restriction, oral antibiotics, and lactulose. And when you say oral antibiotics, the gut sterilizing antibiotics, we used to use neomycin, went off to vancomycin, but now you have rifaximin at hand, which can be used. And you give lactulose orally or as enemas, because it creates a better milieu to prevent hepatic encephalopathy. And you have to manage the concomitant ascites. Right. Now, we'll touch on different aspects of GI surgery that or non-GI surgery that you might face. Cholecystectomy. Now, if you're doing a cholecystectomy, one of the problems is that there are some things that you need to keep in mind. And what you need to keep in mind is this, that that's the bile duct. You have the gallbladder out here. The problem with um, cirrhosis is that you've got a bad, let's say, a multinodular cirrhosis all the way across out here. And when you have a bad multinodular cirrhosis, you often have large vascular channels, the caverns out here, that's one. If you have a portal vein obstruction, the body tries and recreates by getting a number of often you have a leash of collateral surrounding that, and that is called a portal cavernoma. So that is your problem. I mean, that is the major problem. So when you're doing a cholecystectomy, the traditional thing is to, if you're forced to, it's a risky process. If you're forced to, and most trials now say that laparoscopy is probably slightly better than open surgery, but then keep an option of doing an open surgery also. You take the gallbladder out here, you clip the artery, and that's very important to be very careful about all the vascular structures coming in out here, and you need to clip it well. Sometimes dissection in this area is very difficult, but having done that, the traditional teaching is you cut into the gallbladder and you leave the posterior wall lying behind. So as a result of which, you don't dissect in this plane, which we normally follow, the gallbladder plate. You don't dissect the gallbladder plate because the plate is often destroyed completely, and you might end up opening up a cavernoma and land up with torrential bleeding. So that's the problem of gallbladder surgery. So believe it or not, that patient was reported as having a normal liver. Unfortunately, we were completely misled by the fact that and this patient had a very bad recurrent attacks. He had stones in his bile duct, and you can see that he has little pigment type stones in the gallbladder. So the principle is that we've very carefully done that bit, and you can see that already a little bit of dissection is not really bloodless out here. So what you inevitably do is, if you're forced to do something like that, you open up the gallbladder, and that's some of the things that we've done, unless you have a complete mesentery. If you have a complete mesentery, that's all right. So here we are leaving the posterior wall behind. And having left the posterior wall behind, you carefully take out all the residual stones. And we normally keep a gauze out here so that you don't have the stones floating around all over the abdomen. And having done that, the next thing you would like to do, honestly, is to use diathermy to destroy the mucosa behind. Now, herniorrhaphy, that sometimes comes up, and sometimes your choice is actually taken out of your hand, really. Why? Because you end up with an ascites and you have an umbilical hernia out there. So sometimes the skin gets damaged and you have an omentum sticking in out here. So you're forced to do something about this patient because you have a omentum plugging that hole in the skin. Difficult situation because with it being exposed to the surface, you have a tendency for infection, so you can't use a mesh. And sometimes what you need to do actually is to repair this. Ideally, if you have to do it without a perforation, then you can do an extra peritoneal repair. You have the peritoneum out here, so if you don't have the omentum out there, you can actually do an extra peritoneal, stay outside the peritoneum and do an extra peritoneal repair. You can put in a mesh in this plane. Similarly for an inguinal hernia. Hi, mute your connections, please. So in an inguinal hernia, you can choose to go back to your Liechtenstein repair so that you stay extra peritoneal. You might choose to push the mental, you dissect it out, push it back, and then put in the mesh on top. So these are the techniques that you might choose to do. Unfortunately, if you have a situation like this where you have a omentum coming through, then you're in a bit of a soup because now the peritoneum has been opened. So you might need to actually go ahead and do a formal repair. But then the problem is that you would then have a problem of leaking of ascitic fluid. Like this chap came up with a massive ascites, and you can see that that is the omentum sticking through. So the problem here is to evolve a technique whereby the ascitic fluid is doesn't form, or at least is kept under control. And what you might choose to do is, if you have, that's the abdomen and you repaired that, you might choose to put in a Levine shunt. Put in a Levine shunt where one end comes in out here into the abdomen, and that has the perforated branch, and you have the other end heading up into the jugular, patient's jugular vein. So you can put in a Levine peritoneovenous shunt. So that's one of the options. Or in this situation, the patient was medically better controlled once he was admitted, and we gave him aggressive treatment with diuretics after repair. So it's vital to make sure that the sanctity of your repair is kept intact, because even though it's in a difficult situation. So that's some of the options that you do have when you have a hernia with a um, with a tense ascites. Colectomies, that's the other problem. The colectomy is a problem. Why is it a problem? The reason it is a problem is, don't forget that you have portosystemic anastomosis. And some of these anastomosis actually lie around the colon. So if that's the colon, you have plenty of huge anastomotic veins which sort of lie around two main areas, and two main areas are the main problems. A, around the splenocolic ligaments close to the kidneys, around the hepatic flexures, and around the kidneys as well. So these are areas which are risky. And you also have a very distended inferior mesenteric vein and an equally distended superior mesenteric vein. So you need to be very cautious about this. The usual nowadays, we've had a randomized controlled trial, and that actually says that laparoscopy might in a way be better because of all the energy sources that you have. But obviously that has to be played by ear. If you're more comfortable doing a quick in and out for a, let's say, a cancer of the hepatic flexure, you're better off doing it open. If you choose what you're comfortable with. Again, the problem is with an open surgery, if you've given a very large incision, the problem is getting it to heal without problems. Where if you have an ascites that tends to rupture through and it comes through the fluid tends to come out through the holes that you've made. And as a result of which, what happens is that you have a breakdown of the wound and multiple problems, which is why people suggest that you might be better off doing a laparoscopic colonic surgery rather than an traditional open surgery. In bariatrics, I'm sure Rudrajit would be able to tell you better because he does a whole lot of bariatrics. But what the papers say is, though, the why bariatrics? Because you have a problem with nowadays we do accept that non-alcoholic steatohepatitis is one of the causes of cirrhosis of the liver. And for that, ideally, a switch operation might be best. But then the moment you do a switch operation, the huge amount of fluid loss and fluid change challenges make it a major problem, which is why one of the suggestions is that you do a what is perhaps the first line of bariatrics is you do a sleeve surgery, you do a gastric sleeve surgery. So there we are. So that's one of the things that is suggested. If you're, of course, if you want to do a cardiac procedure, you can do a CABG, and the traditional is to use the octopus and do a CABG on a beating heart without using heart-lung bypass. Thoracic procedures, particularly for hydrothorax. So you have a hydrothorax, you do a VATS, a minimal access surgery, because sometimes what happens is the cause of the hepatic hydrothorax is that the diaphragm has little holes in there, and you might be sensible to do a minimal access surgery and seal off those holes from the thoracic side, going through the thoracic sides and put in stitches and seal off the holes. And the other great treatment for hepatic hydrothorax, like ascites, is a TIPS procedure. So you can use a TIPS for a hepatic hydrothorax as well, and that works very well. Right. So that is all about surgery, non-hepatic surgery in portal hypertension and cirrhosis. So the next is surgery for portal hypertension and ascites. Now for that, the important thing to realize is that's the chart. You have a portal hypertension, You can do a non-shunt surgery, which are devascularization. You can do a shunt surgery, which can be a selective or a non-selective. And you can do an orthotopic liver transplant. You can either do a living donor transplant or a deceased donor liver transplant. So that is, in summation, the sort of surgery that will be done. And I'll give you an algorithm just before we finish. So for portal hypertension, the first is to understand what the anatomy of a portal hypertension is. For a start, the liver is at fault. So if the liver is at fault, the two veins that get the problem are the portal vein and the splenic vein. So you have both fairly distended. So now that you have a distended vein because of blockage, it tries to find alternate pathways. And how does it try and find alternate pathways? The pathways are as follows. You have a distended coronary vein which drains from there to there. That's the correspondence of the corresponding to the left gastric artery. You have a distended right gastric vein. You have distended right gastroepiploic veins, and you have distended left gastroepiploic veins, and huge veins around out here. These are the short gastric veins. Right. Now, they all take the blood essentially away. So, where do you think it goes? What does it anastomose with? It obviously goes up here, but where does it go after that? That's something that you need to. These are the varices, the esophageal varices and the gastric varices. So which vein does it communicate with? Anyone? For a start, yeah. So you have diaphragmatic and infradiaphragmatic veins and the azygos veins. Absolutely right. So you have both. Why doesn't it drain? You see, the IVC ends out here. So you have to have a systemic circulation, some representative vein out here. And you're absolutely right. What you do have out here are the azygos and the hemiazygos veins. And the important thing is, because of the back pressure and the drainage that is happening, that becomes extremely distended. Having become distended, the classic way that it actually drains into the azygos and hemiazygos are through horizontal channels. Okay, so I want you to remember that. And also, in trying to remember that you remember that we went through a CT scan of the upper abdomen while we were doing this, isn't it? So I'm going to go back because there's something I purposely didn't ask you at that point in time. And this is it. So that's a CT scan. I've shown you this CT scan, and as I want you to tell me what is number one. Anyone? Number one.
Right lobe of liver.
Number
Left
two.
lobe of liver.
Three.
Spleen.
Number four.
Aorta.
Number five.
IVC.
Very good.
IVC.
Number six.
Portal
Portal.
Very good. Number seven.
Caudate lobe.
Okay.
Caudate lobe, sir.
8.
Stomach.
Okay. Now I showed you the hugely distended veins, didn't I? These are the hugely distended veins. But there's one vein I purposely didn't mark out. That is this. That is 9. Now you tell me what is 9. Now that you've seen that diagram that I showed you. Very good. Absolutely run. Well done. So that is the azygos vein. I purposely left it out the last time I went in because I thought I'd show you that diagram and then. So now you realize that that is actually number 9 is the azygos vein. Okay. Okay, remember that, because that is a pointer that this is a portal hypertension. Well done. I think that was excellently done. Well done, chaps. Right. So now we go to the next one. So now we have, this is the anatomy of the portal hypertension. So what are the things that we need to be careful about? We need to be careful about the following. We need to be careful about the coronary vein, which drains in our, which takes blood away from here. Need to be conscious about the right gastric, the right gastroeploic, left gastroeploic, large veins out here. Okay, and what are the veins that it drains to? We know what are the drains it drains to. It drains into the azygos and the hemiazygos by
Horizontal
transverse
channel.
horizontal channels. Yes, very good. And you have the supradiaphragmatic on both sides. You have the infradiaphragmatic on both sides. So if you understand that, then we'll go through the separate steps of different types of an operation, and it'll be easier for you to appreciate that. Right. Right. So first step is a devascularization process, and this is from Bloomgut's, and the first is the HASSABS, HASSAB, HASSABS operation. And what was the steps of the operation? What he did was, number one, he removed the spleen. Okay. Hang on. Let's just get the spleen in. So he removed this, he did a splenectomy. That went out. And together with that, he did a devascularization of that part of the greater curve. You can see the vascularization is still there. He dissected out here, right up to the diaphragm, opened up the hiatus. In doing so, he cut off the infraphrenic, the supraphrenic. And what he did also was do a devascularization of the, you can see that he's tied off the azygos and the hemiazygos veins. So that is completely tied off. And the operation was ended by bringing the dissection down the lesser curve and up to, he devascularized the left gastric vessels. So the left gastric vessels were taken out, both the vessels and the coronary vein was taken out, right up to here. So obviously the thing that went together with it was the vagus nerve, right? So you had to do something. What you needed to do was a pyloroplasty out here. So that was the entire operation of HASSAB. So it was completely dependent, how you would say, where did the blood supply come from? The blood supply came from, the gastroepiploic, right gastroepiploic, and a portion of the right gastric. So you essentially devascularize that complete part of the esophagus and the stomach. So that was completely devascularized. Okay, right.
So can you again repeat the vessels?
Yeah, will do. Sure. Of course I will. First was he did a splenectomy. He removed the splenic vessel. So what were cut? You see, the left gastroepiploic vessel was cut. The short gastric vessels was cut all the way around the fundus. The inferior phrenic vessels on both sides. The superior phrenic vessels on both sides were cut. Okay? Is that all right? First stage.
Yes.
Second stage, what he did was, hang on, he came down to the lesser sac. And the moment he came down to the lesser sac, what was cut? The left gastric vessels were cut. Left gastric vessels met the left gastric artery and the coronary vein. Okay, so what was left? What was left was the right gastric, the right gastroepiploic. Okay, so now he went in ahead, and the dissection was actually first a splenectomy, clearing up the complete fundus. Next step was clearing up the lesser sac, taking the gastric vessels down. And now the third stage was he went up, he dissected up the peritoneum up out here. Okay, so that's the sequence of the HASSAB's operation. Went up to 12 centimeters, and what he did was, you can see out here that he actually took off these are called the adventitial vessels, the azygos and the hemiazygos. Okay, up to 12 centimeters. So that's 3. Then what he do? Right. So the vessels in sequence was left gastroepiploic, short gastric vessels all the way up to the cardia. Okay. Left gastric vessels and the coronary vessels work your way up to the hiatus, where you take off the superior and the inferior phrenics on both sides. You cut the adventitial vessels that are leading up out here, and you completely denude that area, which meant basically if you're denuding that area and you're doing a complete devascularization out there, you were actually removing the vagus also. So you needed to do a you also needed to do a
Pyloroplasty.
pyloroplasty. Yes, that's right. Now, at about this time, Seguera came in. And the sequence of Seguera, the steps are, and it's very nicely labeled out here. The first step was a splenectomy. Okay. And having done the splenectomy, you remove the left gastroepiploic again and the short gastrics all the way up to the fundus. You take the inferior phrenic vessels and the paraesophageal vessels. The dissection here went up into the hiatus, and what Seguera did was he did something. What he said was, you need the adventitial vessels. After all, if you think about it, you need the azygos and the hemiazygos, isn't it? Because that takes the, if it just doesn't drain the portal, in this situation it is draining the portal veins, but it also has an effect in draining all the other fluid from the rest of the abdomen. Okay, so what he did was he left the adventitial, which means he left the azygos and the hemiazygos, and he took off the horizontal branches. Okay, denuding it completely up to 12 centimeters. And the traditional operation that Seguera, I-U-R-A, Seguera, S-I-G-I-U-R-A, Seguera's operation was, he did a thoracotomy first, did that part first. Then 4 to 6 weeks later, he came down and did the abdominal part. But what is right now done is you do it at the same stage. You dissect up, you open up the hiatus, and the advantage of that is you take off the inferior phrenic and the superior phrenic vessels also. But what he did was he didn't take the azygos and the hemiazygos. What he took off was the horizontal branches. And in taking off the horizontal branches and you denuding that, obviously, so stage two was extending up the hiatus. 3 was, what he did was he did an esophageal transection. Now, the way he did that esophageal transection and the way we do it nowadays is completely different. What he did was, if that's the esophagus, he opened up the esophagus with a horizontal incision. I'm going to wipe that off before we go in. And what he then did was he actually cut the mucosa. So the mucosal tube was here. So he cut the mucosal tube somewhere in the middle. So he actually, now what you have is, you have the mucosal tube cut out here. Mucosal tube cut. And then what happened was, essentially, he left the posterior wall intact. The reason for keeping the posterior wall intact, can you chaps just hold on for a sec? Hello, sorry about that, chaps. So essentially you had the posterior part of the muscle tube intact. So then what he did was he sutured it up. He sutured up. So that was the esophageal transection that Seguera did. So you essentially now have a tube out here which has been repaired inside. So Basically, the concept, what he said was, Hassan thought the external veins were important. It's not. What Seguera said was, actually you have large vessels, the submucosal vessels, as you can see in an endoscopy. So unless you transect that and stitch it up, that patient would continue bleeding. So there we are. So that was his step of esophageal transection. Nowadays, what do? We use, I'll show you what we do. So, but the essence of this thing was, again, you have to divide both the vagus. So because you've divided both the vagus, you then end up with a pyloroplasty. So Seguera, splenectomy, devascularization of the greater curve, left gastroepiploic, short gastroepiploics. Next, you go up to the hiatus. You take off the transverse branches, not the adventitial branches. You do a esophageal transection. You do a proximal gastric. You remove the vessels in along the lesser curve out here. So that's step number 4. And step number 5 is you do a pyloroplasty. So that's the sum total of the Seguera. So I'll show you what we tend to do nowadays. And
Sir, reason for leaving the posterior wall in case of, sir, esophageal dissection?
what he said at that point in time, and this was Seguera's personal paper, he said, unless you do that, what happens is you might end up with a twist. He said, I won't be able to get the esophagus back together without a twist. That was a time that there weren't any staplers or anything, hand suturing. Okay. So he said, if I keep the posterior wall intact, I've taken out the external vessels. What have I taken off? I've taken off the horizontal vessels. Okay. So the muscle, all the vessels and the muscles have been taken care of. So now I'm going to cut the muscle half, expose the mucosal tube, cut the mucosal tube and stitch it so that now I can take the submucosal distended vessels. Okay, but I didn't want to cut it completely, because then because it has such a lot of distended veins that I might not be able to, I might end up putting the esophagus back together with a bit of a twist. I didn't want it to twist. That is his rationale for not giving the traditional through and through cut and stitching it again. Okay,
Okay, sir. Okay,
that
sir.
was his original description. So nowadays, what do? Nowadays, we do as follows. The first step is, of course, do a splenectomy. And having done a splenectomy, we denude that whole part of the greater curve, left gastroepiploic, short gastrics, all cut all the way up out here. All the way up. So next step is, and I'm going to, hang on, this thing is coming in the way. So the next step is that we do a dissection of the veins out here. When we do that dissection of the veins, nowadays what you normally do is you dissect the anterior vagus out here. Okay, so that now you can see that we've kept the vagus intact, and you take the horizontal branches that come in from the zygos and the hemiazygos. These are the veins that are taken out completely. And the distance that you do it is for 12 centimeters. You make sure that the hiatus, the esophageal hiatus is enlarged, as a result of which now you've taken out the infraphrenic and the supraphrenic branches also. Right. So 12 centimeters up out here. Having done that, now you come down to the lesser curve, and having come down to the lesser curve, the dissection is you take out the gastric vessels, the left gastric vessels is taken out together with the coronary vein, which is also follows out here. But when you do the dissection out here, you're careful about the nerve, the anterior vagus. You normally do take the posterior vagus nerve completely, but what you now do is you dissect down out here up to the, hang on, let me just, up to the nerve of lateral jet. You keep the nerve of lateral jet intact, which now means that you have the vascularity of the pylorus left intact. So you don't need to do a pyloroplasty. Okay. So effectively now what you have is that you've done a complete dissection. You've just left the right gastric inflow and the right gastroepiploic inflow. You've actually taken out all these. So that's a far more extensive devascularization, and you're completely dependent on blood supply coming in from here. Now that you've done that, your next step is that you need to do you will need to do what is normally done is you do a little gastrotomy, and through that gastrotomy, you put in a stapler. Now, the problem with the size of the stapler is you have to have a 25 and a 29 handy. Particularly, if you've done a sclerotherapy, there's a, if you've done a sclerotherapy, there's a frightening amount of fibrosis that you find around out here. As a matter of fact, dissecting this part is one of the most difficult things to do if you've already had a sclerotherapy. And one of the persons who had a huge paper out here, you might have heard of him, is Adarsh Chaudhary, who's right now with Medanta, with Dr. Aranya. They had a paper from All India Institute where he effectively, and that was one of the sentinel paper why people moved out of sclerotherapy into banding. But the moment you do a sclerotherapy, it gets completely, makes that frozen. It's like a frozen hiatus. And dissecting there is one of the most tough things that you can be asked to do. So that is one of the things that you need to remember. So these are the steps of a modified Siguera operation as we do it nowadays. So
Sir, what are the circular staplers, sir, where we will put?
You put in the circular stapler from here. Hang on, let me just draw it out for you. You put it in through that gastrotomy all the way up out here. You tie in, that is what you do. I'll come to the next thing. So that is the picture. Okay. Is that does that picture make it clear? You've done a gastrotomy, you
Yes.
put in the circular stapler, you put it through out here at the level of the diaphragm. Where do you do a tie? You do a tie, a purse string tie is put around the esophagus, and the anvil is passed above that tie, and you do a stapled esophageal resection out here. Usually, if you have been fortunate enough to have your gastroenterology colleagues do your banding, you can get away with a size 29. If not, if unfortunately this patient has had a sclerotherapy, then unfortunately the only thing you can do is put in a size 25. And then if you've put in a size 25, sometimes you need to come back in later and do esophageal dilatations because 25 is very small. Okay, but at the end you close the gastrotomy and that's the end of the thing. Okay, I knew it can be slightly confusing, so I put this picture from Bloomgart as well. So anterior gastrotomy, put in the stapler, you've put in the purse string around this esophagus at the level of the diaphragm, you open up the anvil so that it it fits the 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 trick out here is not to completely dissociate like we normally do. This type of stapler is something like the PPH gun that we use. The PPH gun where the anvil is stuck. It can't be removed. So you put in a purse string and then you close it and you fire it. So you have an esophageal transection with this. Now the only difference out here is because you've done a complete and exhaustive devascularization out here, it is traditional to keep the patient on TPN total parenteral nutrition for 5 to 7 days. Do a contrast study with a water soluble contrast. Make sure that the patient doesn't have a leak from here, and then allow food. So that is one of the things for a Siguera procedure. Okay. Any questions about the Siguera? Can we move ahead?
What's the use of
Yes.
gastrotomy, sir?
You close the gastrotomy. Sorry, that was the question, was it?
Yes, sir.
You close the gastrotomy at the end of the procedure. You don't need to do a pyloroplasty because you've saved the anterior nerve of lateral jet. Okay.
Sir, could you repeat the dissection of the fundus 1 minute?
Yeah, sure. So let's go back. So what you need to do out here is, if you remember, we had the spleen out here. We've taken the spleen out. So the moment you take the spleen out, you've taken out what? You've taken out the, hang on, let me just take it out here. So essentially, what the dissection that you've done is that's the left gastroepiploic. So you've removed that and you've taken it all the way out here, right all the way up to here, which meant basically that you will have tributaries from the inferior phrenic out here as well. So you need to remove that completely. Okay, that has been completely denuded. What you also do is you denude till you leave that arcade, but you do a complete devasc up till here. So the whole of the greater curve, except for a bit where the right gastroepiploic comes in, is left without, denuded. It's completely, and you stay close to the stomach. Okay. So having done that, now what you do is you address the hiatus, where you remove the blood vessels, or which are the horizontal blood vessels, which are coming in from the azygos and the hemiazygos. But before you do that, you ensure that you move the anterior. Let me just get this out. You move the anterior vagus from where it is, and you move that away so that you have the anterior vagus out here. It has to be done very cautiously. Now what you do is you leave the azygos and the hemiazygos intact, but you take off the horizontal branches up to 12 centimeters. Okay, 12 centimeters there. And which means you've basically, now that you've opened up the hiatus, you can also well appreciate that we've taken these vessels out also, the supraphrenic and the inferior phrenic vessels. Having completed that, you now concentrate on the greater curve. Having come down to the greater curve, what you need to do is take off the left gastric, posterior dissection. You make that area go behind, and that is where, if you've had sclerotherapy, you have to be very cautious, because sometimes the esophagus open and the cardia opens up. Sometimes it's a complete block of tissue, and you take the left gastric and the coronary vein. So let me take out the blue color. That's the coronary vein. We've removed the coronary vein, but we remove that, and we then come close to the stomach, and we take out all this right up to the heel of the nerve of lateral jet, the anterior nerve of lateral jet, that crow's foot. We come till up till out here. So you can well imagine that now what the stomach is completely dependent on is this and the right gastric. Okay, so it's a completely exhaustive dissection. Having done that, what you now do is you do a gastrotomy, and you put in the stapler, the circular stapler, and then you fire. You fire at the. You have to put in a purse string at the level of the diaphragm. You make sure that the stapler is open enough at that point. Tighten it around, and then make sure that it is tightened very well. And then you deploy the stapler and you cut. So you have effectively, that is the way you're done. You make sure that your donut is intact, and once you're out, you close up the gastrotomy, and usually in 2 layers or a single layer extra mucosal stitches. And having done that, you keep the patient on total parenteral nutrition for 5 to 7 days, because it sometimes leaks because of the extensive devascularization that you've done. Make sure with with a water soluble contrast that there's no leak, and then you start the patient feeding. If you've been unfortunate enough not to be able to use a 29 but you've used a 25 size circular stapler, that patient is almost certainly going to need repeated esophageal dilatation. So that's the complete spectrum of the modified CCsurge procedure. Okay.
Thank you, sir.
Sir,
Right.
why are you doing esophageal dissection, sir? Yeah.
To disconnect, that's called the porta azygos disconnection. Why do we need to do a disconnection? You see, this is the portal vein. Hang on. This is the portal vein. This part is coming in from the portal vein. Okay. Blood is coming in from the portal vein. Splenic vein from here. And that is the azygos. It's draining into the azygos vein out there, isn't it? It's draining into the azygos vein out there. So unless you cut it across, you can't stop this flow going in and out. See, what we've done is we've removed the horizontal branches. So if you consider the esophagus out here, that's the esophagus. Okay. That's the mucosa. So don't forget, you actually have blood vessels both ways. You have blood vessels out here on the surface. Okay. But you also have blood vessels out here. So if we've taken the transverse feeding vessels off, you have the channels that communicate inside, isn't it? And am I making myself clear? Okay, if I draw it for you hang on, that's the esophageal tube. That's the mucosa. And you have blood vessels out here on the surface and inside, on the surface and inside. Now, if I've taken these horizontal vessels out, removed it, I've removed them, I haven't addressed this. Get it? Unless I do a transection, I can't address the submucous vessels. Do you appreciate that? Hello?
Yes, sir. Thank you. Yes, sir. Thank you, sir.
Okay, so that is the reason that you need to do a transection. As a matter of fact, let me tell you, we had something called a Tanner's operation. That was called the Tanner's submucosal porta azygos disconnection. Do you know what that operation was? I didn't want to talk about it, but you actually put in a incision out here and stitched it so that you had the principle was that was a portal, that was a systemic, and that was called the Tanner's operation. Tanner's porta azygos disconnection. Obviously, they didn't realize that you actually had small vessels going in out here. So that wasn't very, it was sounded very nice, but it wasn't a very successful operation. Okay. So right now, the operation that we do subscribe to is the modified CCsurge. Okay. Any questions?
So that 12 centimeter, you are telling that 12 centimeter from where?
From the cardia.
Cardia till 12 centimeter above.
Yeah, above.
Esophagus.
It's quite a bit, isn't it? 12 centimeters not. So you have to make the hiatus fairly large, dissect out the pericardium from the esophagus, and then go in and reach that.
Okay, sir.
It's something, almost like a transhiatal excision of the esophagus that you do. So you have to widen the hiatus enough to do it. But the advantage of doing that is that you don't forget that you don't have to open up the chest, isn't it? Get it?
Sir. Yes.
Yes.
Okay. Now that is the result. I mean, basically, op mortality, rebleed rate, chronic encephalopathy, its spectrum, the thing is all the way across. Obviously, the modified Segura had the least amount of operative mortality. But if you look at the 5-year survival between that, it wasn't very, too much of a difference. It was just about the same. So 73 to 85 and Hassab, Segura, original 32 to 75, 5-year survival, modified Segura 23 to 72. Okay, right. So we come to shunt surgery. That's all about devascularization. So shunt surgery, now we'll concentrate on shunt surgery. Any other questions on devascularization? Okay, then we'll go ahead. So shunt surgery can be selective or non-selective. Now, non-selective shunts can be a Porter cable shunt or a mesenterical cable shunt. The proximal splenorenal shunt with splenectomy has been described in the non-selective shunts. There's a bit of an issue about that, but recently I think Dr. Sujoy Pal, who is the I think he's going in for heading the GI surgery at All India Institute, Delhi. He labeled this because that has been described in Bloomgart under the non-selective shunts. And you also have a splenorenal shunt without splenectomy, something that was popularized by at Chandigarh by Dr. Mitra, who was the head of the Department of Pediatric Surgery, particularly the splenorenal shunt without splenectomy. So we've had a number of Indian surgeons helping us with shunt surgery. Of the selective surgery, and that was Dr. Pal's paper in from All India Institute in 2012. Selective surgery, you have a distal splenorenal shunt that's called the Warren's shunt. We'll spend a bit of time on that. You have the small diameter interposition 8 millimeter H graft, Sarphase graft, and that was, despite being a portocable shunt, that has been labeled up as a selective. So obviously you have to use your discretion. The other one, which is again being described as a selective shunt, is the coronary cable shunt. And that was by a Japanese surgeon called Inokuchi. Right. So sounds very confusing. I know it's confusing. I'm going to try and make it very simple for you. So you need to understand again, the anatomy, like we had the anatomy of the devascularization process. You need to understand the anatomy of this of the vessels. So shunt surgery, the main players, portal pre-block. You have a traffic jam. Who are the people? Which are the roads before the traffic jam? And they are as follows. You have the splenic vein. You had the portal vein. You had the superior mesenteric vein, and don't forget you had the coronary vein. Okay, that's straightforward. So you need to find out, because you're doing shunt to some other vessels, you need to find out who do you transfer to. So who are the main players where they're in the systemic circulation where there's no block? So these were essentially the IVC and the left renal vein. So pre-block, portal vein, I want to transfer shunt from portal vein or superior mesenteric vein or splenic vein or the coronary vein to the IVC or the left renal vein. So you can well imagine that if you have a problem in the IVC, if you have webs in the IVC like you do have in a Budd Chiari, then this shunt surgery, this particular type of shunt surgery may not work. So there we are. So we are going to discuss the one that is sometimes asked is the Warren shunt, the distal splenorenal shunt. Distal in terms of spleen. So distal to the spleen. Proximal is close to the spleen. So distal splenorenal shunt meant that it was distal to the spleen. So what was done? So the first step was that the colon was shifted down. Okay, colon was shifted down. You cut into the gastrocolic ligament. And having done that, now you move up the stomach. So the stomach has moved out. The next step is that you need to get the pancreas out. So the moment you do that, you get the pancreas out slightly. And when you do that, what happens is that you need to be careful about veins that actually come in from the pancreas. This is the part of the difficult dissection, because you have veins coming in from out here. And these are the veins that you need to remove. So you need to remove all these veins. So these are removed. Now that you've removed that, what is done is, in this stage, now you cut that end. That end is cut. This is mobilized. The splenic vein is mobilized, and it now is anastomosed. You cut it, the way it's cut is in a bevel. It's cut as a bevel, so that now you can actually anastomose that to the renal vein out here. So that is the way that it is anastomosed. The way to do it is to take a small little chunk of the renal vein out so that it doesn't seal. So that is the spleno-renal shunt. The moment you do that, you have to take off the adrenal vein, because otherwise it gets congested, but you do leave the inferior mesenteric vein intact, because that forms a conduit to, a bit of the blood goes out here, some bit of the blood goes out here. There's one other thing. Now I'm going to ask you that. You have now cut this, which meant that all the outflow from the stomach now, which is coming through the short gastrics, comes in out here and drains in out here. So what happens to, now this is cut. Let me get another color out here. That is completely cut. So now tell me what happens to the blood that the rest of the is traveling up here. What happens to that blood? Won't that now come up the coronary vein and go up beside the esophagus and still create a problem of varices? Do you understand what I'm trying to say? I've bypassed this. So all the blood that is coming up, let's say through the right gastroepiploic, down the left gastroepiploic, down the short gastrics, through the stomach are draining in out here, and that is going through into the left renal vein. But there's also a fair bit coming up from the rest of the intestine. Now that we've cut this, that has no access to this anastomosis that we've made. And if it has to reach that, what does it need to do? It will need to come up the coronary vein. A bit comes in down out here. The rest goes up into the esophagus like it normally does. And you have varices, and that keeps on bleeding. So part of the Warren shunt is not just to cut the splenic vein. You have to cut and transect the coronary vein also to stop that flow coming in out here. That is what makes it a selective shunt, because you have some amount of blood still going, forcing its way through into the liver. So if you were to divert it completely away, and we'll talk about that when we are doing a Porter cable, think of that. Normally only 30% comes in through the hepatic artery. 70% is a portal vein study. If portal vein drainage, if you take that bit completely away, then the liver will atrophy. You'll land up with liver failure. Okay. So again, we're going to go through the stages. Let's go back again. We'll replace things as they were. So we go ahead. The first step is to expose the splenic vein and expose the left renal vein. The way to do that is you go into the gastrocolic omentum, gastrocolic ligament, and you bring the colon down. You get the stomach up. in bringing the colon down, remember that you have very big vessels, sometimes collaterals through the sphenochoric ligament, and you need to be careful of doing that. The next step is you rotate the spleen upwards. In rotating the spleen upwards, you get plenty of transverse tributaries from the spleen into the portal vein, which are quite fragile and quite large. So you need to take those very carefully. Having done that, now what the next step is that you actually cut the splenic vein obliquely like that, and you've dissected out this left renal vein. The adrenal vein is taken, and you do an anastomosis between the splenic vein and the left renal vein. So it is distal to the spleen, so it becomes a distal splenorenal shunt. But to stop the rest of the outflow traveling up the coronary vein, you have to tie off the coronary vein. So the steps are, again, colon brought down, stomach going up. If you can go through it again, because this is the operation that is asked. DSRS. Gastrocolic ligament is cut, colon moved down, stomach moved up, pancreas moved up, and you take the horizontal, the branches that are coming in into the renal vein, into the splenic vein, mobilize the splenic vein, expose the renal vein, take the adrenal vein out, and you cut the splenic vein slightly obliquely. That is the way you would cut it, so that now that you try, when you move it across, you can actually anastomose it to the splenic vein, to the left renal vein quite nicely. It is worthwhile taking a small disc of the renal vein out so that it doesn't seal up. So having done that, that's absolutely fine. So now you have a situation where you've cut the splenic vein, but you also need to cut the left coronary vein. Otherwise, the outflow from the rest of the intestine will still keep on going up there, and you won't have the benefit of getting collapsing the varices. That is why you've done this operation. Okay, right. Can I go forward now? Any questions about DSRS, the Warren shunt?
Sir, why they have differentiated as non-selective and selective, sir? What is that mean, sir? Non-selective and selective.
Because if you've done a selective, you have a certain amount of blood still flowing through into the liver. Get it? The original description was a portocaval, where you got the portal vein and anastomosed it to the IVC, which means all the blood came into the IVC, nothing into the liver. Okay? Versus a selective shunt, because it's a selective shunt because it's you've chosen not to drain the actual portal vein or the mesenteric vein, superior mesenteric. You're draining the splenic vein. That is why it's selective. Okay, and you have some amount of blood flow going through into the liver, so that the liver, the blood that comes up the portal vein has hepatotropic factors. I'll discuss that when we are going in for the non-selective shunts. Okay. Right. So the next operation that was done was, let's suppose you had hyperspasm. Everything else is the same. But in this case, what you do is you take the spleen out. Once you've taken the spleen out, you do a proximal. If you now bring this part of the if you bring this part of the splenic vein and anastomose it to the renal vein, that is called a proximal splenorenal shunt. So if you anastomose that, it's called the distal splenorenal shunt, which is traditionally the selective. And I can appreciate that the moment you do a proximal splenorenal shunt, why is it called a non-selective. The reason it's called non-selective is that if you now can well imagine that every bit of blood from here, from there, all flows down into the left renal vein. The moment you do a distal splenorenal shunt, you have a proportion coming out here, which is the one that drains the greater curve of the stomach and the fundus, and a bit that was actually flowing in from the rest. Let's suppose fluid coming in from blood coming in from the small intestine, the colon, the right side of the colon, that still drains, has to drain into the liver because you've tied off the coronary vein. So proximal splenorenal shunt, you don't tie off the coronary vein. So that is still left there. In a distal, if you were doing a distal splenorenal shunt, you tie off the left coronary vein.
Sir, in
Okay.
proximal splenorenal shunt, again there will be varices, na? Because coronaries are still supplying. We are not tying it.
No, but then you need to leave it. Otherwise, what happens is, think about it, you've done a devascularization of the stomach, isn't it? When you've done the splenectomy. You've done, that was the spleen. Think about it. You've taken all these vessels out, no? Right.
Okay, no varices then, because
No, but
this
you
is
still
just-
have, I mean, which is why it's not as good as the other thing. You're absolutely right, because you still have the coronary vein draining a fair bit out here, isn't it? But the outflow now comes in because of the splenic vein being drained into the left renal vein. That was the splenic vein. You've transferred that out here into the splenic vein. So the varices, because you've tied off a large amount of those blood vessels out here, a majority actually shunts into this renal vein. Okay.
So
Yes.
yeah, once again, why selective is DSRS and why non-selective PSRS?
Because, yeah, because technically, if you've done that, see, that is why we are not tying off the coronary vein. If you don't tie off the coronary vein, blood flow, that should, think about it, you've anastomosis out here. So the blood flow that comes up the superior mesenteric, what does it do? It comes into the splenic vein, isn't it? Flows into the left renal vein. A bit that should have gone to the liver now comes up through the coronary, through the stomach, into the short gastrics, and through the stomach into the left renal vein also. So the blood flow to the liver is taken off far more by a proximal splenorenal shunt. I mean, more completely by the proximal splenorenal shunt. It becomes a bit confusing the moment you said selective and non-selective. I personally think that this is why, what I've done is, hang on, I've said splenic vein anastomosis. Okay, splenic vein is the distal splenorenal shunt. Remember that is traditionally always the selective operation. Selective shunt is a distal splenorenal shunt. Proximal splenorenal shunt has, because you're taking the spleen out, you're doing a fair bit of devascularization also. Remember that. Okay, and you're also leaving the left coronary vein so that blood flow, which, a portion of your blood flow coming up the superior mesenteric flows through into the splenic and then into the left renal vein. If you have a block out here, a majority will then keep on flowing out here, isn't it? Think about it. What I now have is, why is it that proximal splenorenal shunt is non-selective? That's a blockage. That's a cirrhotic liver. Okay? Blood flow can't go that way. So what it does is it flows through the passage of least resistance into the splenic and into the left renal. So you have very little flow going up because you have a blockage in the liver. The moment you don't do that. The moment you do a distal splenorenal shunt, what have you done? You've tied that off and you've anastomosed this out here. So effectively, what now happens is that all the blood vessels, that all the distended vessels, that I won't use red, I'll use blue. All the blood vessel that was there now drains through the short gastrics, drains through the left gastroepiploic into the splenic vein, and through the splenic vein into the left renal vein. Okay. I've tied this off. So what happens to the outflow out here? That can't go in out here. It can't. So it has to go up. So it should try and escape through the left coronary vein, and we've tied off the left coronary vein. So now can you imagine, with a distal splenorenal shunt, I'm forcing some amount of blood into the liver. Clear? Again.
Yes. Yes, sir.
Is it clear now?
Yes, sir.
Yes, sir.
Again, see, because I'm tying this off, isn't it? So blood from the fundus drains in out here, and then through the anastomosis that I've made in the left renal vein. But a proportion is going up towards the liver, isn't it? It can't come in out here. So it can escape by the left, the coronary ligament, and I've also tied that off. So I'm inducing some amount of blood to go to the liver. So that makes it selective. That makes the proximal splenorenal shunt, where this shunt, the proximal splenorenal shunt means that this is open, na? And you know that fluid will always go through the area of least resistance. So you have a problem with the liver, difficult flow out here. You were trying, you have nothing left to force it. All of it comes into the spleen and then into the left renal vein. Which is why proximal splenorenal shunt is supposed to be a non-selective shunt. It's shunting away all the blood flow. And a distal renal shunt is a selective shunt. It is not shunting away all the blood. Okay.
Okay, sir.
Sir, means the name proximal, the name selective and non-selective means is referred to the amount of blood going to the liver.
Exactly. It's a selective shunt because you're selecting some portions of the portal outflow. You're not choosing the entire thing. Get it?
Okay.
Right. That is why I've said that. So the results of DSRS, operative mortality was 4.7, morbidity 41.7. 1 year survival is very high, 90, more than 90. Recurrent variceal bleed was observed in 2.4, so that's pretty good. Hepatic encephalopathy was 4.8. Remember that we are inducing some amount of blood, and this proves it. You were asking why PSRS is non-selective. 12.5% in PSRS versus 4.8 in DSRS. Okay. SIT is in 14.6. Overall DSRS shunt patency was 97%. So this is the significant thing. Hepatic encephalopathy will occur if you shunt most of the blood out. So you don't, because you're not shunting all of the blood out, it's 4.8 in DSRS, 12.5 in PSRS. Get it? Right.
Yeah.
Now we are going to go into what are we shunting? We are shunting the portal vein and the superior mesenteric vein. So at about the 1880s, there was a person, a Russian surgeon. His name was Eck. You know a lot about Eck. Eck. I don't know whether we have people who love dogs. I love dogs. But what he did was he did I'm sure he had his justification. He did this sort of surgery. He actually, hang on, I can't get this. He cut off the portal vein out here. Why can't I get the picture? He cut off the portal vein out here and he joined it to the IVC. So it was called the Eck shunt. ECK, Nikolai Vladimirovich Eck. That was the chap. He did it on 8 dogs. 7 died, 1 ran away. So couldn't be found. Very sensible dog, ran away from egg. So there we are. But that actually induced a number of people to do it in humans. The problem was with the X shunt was, you can well imagine now, people who were telling me about selective and non-selective, you can well imagine that this was a situation where you had 100% of the blood going away. As a result of it, within 3 to 5 days, you had a 90% atrophy of the liver. It wasn't tenable with life. So, but it has its advantages because it just proved that there was some sort of hepatotrophic factors that come up the portal vein, which cause the liver to thrive. And that is why we try desperately to do a selective shunt. Because if you do a selective, some amount of blood goes into the liver and you have only a 4.8% hepatic encephalopathy. Whereas if you were doing a selective, a non-selective shunt like an X shunt, you know, the dogs actually were fed. The worst was that he fed dogs proteins. The moment they were fed proteins, they had seizures. So the body couldn't handle so much of protein absorption if you had 100% shunting away from the liver. So that was the proof. That was the biggest contribution that Eck had. The other person who used to work with Eck, his name was Pavlov. I'm sure you've heard of the Pavlov's test. So, shunt surgery. After that, what happened was people started using shunts. The way they did a porto cable shunt was they put in a graft. They made a hole in you put in a side Satinsky clamp. You took a bit of a little chunk of the wall of the IVC away. You took a bit of the wall of the portal vein posterior margin away, and you put in a shunt out here, a PTFE shunt. So you had some amount of blood traveling down out here. People were scared that if you put in a small shunt, it will seal up. So they put in large size shunts, 12 millimeter, big size shunts. Guess what? They landed up with encephalopathy. And there were a fair amount of trials which said that the moment you go more than 8 millimeter shunts, if it was more than 8 millimeter, your incidence of hepatic encephalopathy rose up exponentially. Okay. So nowadays they do a small shunt and it stays reasonably patent. So PTFE shunt. So if it was from the portal vein to the cava, it was called a portocaval shunt. Portocaval shunt. If it was from the mesenteric, superior mesenteric to the cava, it was called a mesenterico-caval shunt. Okay. But because it had the potential for taking away most of the blood, I mean, that selective and non-selective was at a time, don't forget that we were using 12 millimeter grafts, and it actually took a fair bit of the blood away. So it almost took a majority of the blood away. And as a result of which we landed up with massive hepatic encephalopathy. And that was why these were called non-selective shunts. You also had another selective shunt whereby if you could actually put in a graft from the coronary to the cava. So you had not all, but a small amount of blood that was transferred out here. So that was called the Inokuchi shunt. That is the coronary caval shunt. But because it didn't shunt all the blood away, it couldn't because it was a smaller amount. So that is a selective. So people who were asking why selective, why non-selective, because if you can induce blood to flow through the liver, it was selective. If you couldn't induce that, it was non-selective. Okay. Right. This was, and I would recommend that people who, this was a fabulous monograph written by Thomas Starzl, who's the father of liver transplant. He was in America. So if you can read that, it's a wonderful read, and it goes through how Eck, this was Eck. This chap was Eck. Nikolai Vladimirovich Eck. So he was the 1880s. He was doing that sort of surgery on experimental basis on dogs, and that was how we learned a lot. It wasn't very successful. That shunt wasn't very successful in what it was trying to achieve, but it actually proved, and that was what he was trying to prove, was he was trying to prove that the liver needed blood traveling through to sustain itself. Anything does, but liver actually grows if you allow portal vein blood to go through it. And this was a beautiful article. Thomas Starzl is the father of liver transplant surgery. Porter was a pathologist at St. Mary's Hospital, London, and Franca Vella was a pathologist at Italy. So that's a wonderful article, and I strongly recommend that you can read it. So basically, the result was, if you had a type of shunt, incidence of encephalopathy, Porter cable had an incidence of 54%, and a mesenterical cable had a 35 incidence of encephalopathy. See, that was the reason that these are called non-selective shunts. You can well imagine that DSRS has an encephalopathy rate of 4.2%. So you can well imagine that that's the difference. Coronary Inoguchi's shunt is a very difficult shunt that has encephalopathy rate of even lower than 4.4. I think it has an encephalopathy rate of around 3%. Okay, but this was the thing. If think about the diameter of the shunt, and that was that was around for quite some time. People just didn't realize that that paper was there. That was a brilliant paper. That was by Sarfe. And what he said was, if you had a diameter of 2 millimeters, no portosystemic encephalopathy. For no portosystemic encephalopathy. The moment you go up to 8, you had a 21%. So if your graft size was 8 millimeter, you had a 21% chance of encephalopathy. And you cut that down by avoiding proteins and giving the patient lactulose. But if your shunt size, the PTFE shunt size came up to 16, see the amount of encephalopathy that you had. It's 64%. And you can imagine that a number of people who had these shunts died of hepatic encephalopathy. So that was the Sarfe's paper, and that was way back in 1995. And that was what he described, and that was the radius of the shunt. That was from his table, and this was the editorial. I mean, it was such a sentinel paper that people put it out in the editorial in hepatology. Okay, right. Now, sometimes you have an extrahepatic portal vein blockage. So what is the sort of shunt that is used out here? You sometimes use a shunt if you can well imagine that, suppose you have something like this and you use a shunt from here to there. So you have a mesenterical cable shunt, okay? Anybody knows the name of the shunt? You use the left jugular vein. It's an autologous shunt. You use the left jugular vein. You harvest the left jugular vein. You harvest the left jugular vein, the whole length of the jugular vein, and you use it out here. Usually the left is used. That is the anastomosis in the recess where the falciform goes in. So you dissect out the left portal vein, and you do an anastomosis between the mesenteric and the left portal vein. That is called the Rex shunt. Remember the name? It's called the Rex shunt. That's the only other shunt that is used. That obviously, because the liver is fine and you're inducing blood to travel through the liver, you um, you don't have an incidence of hepatic encephalopathy. And besides this, is you have a normal liver. You have a portal cavernoma out here, so it's very difficult to approach this area, the hilus, because you have a cavernoma. I told you about the cavernoma in a when you're doing a gallbladder surgery. So if you have a large cavernoma out here, it's very difficult to approach that. So instead, what people do is use a superior mesenteric to a left portal vein anastomosis, and that's called the Rex shunt. Right. Now, it's all, I know, a bit confusing. Now, I want you to take a screenshot of my next two slides, because that is the one that will tell you, that is the synopsis of what we've been doing all this time. So, the treatment. This is the algorithm for definitive treatment. Suppose you have a non-alcoholic or an abstinent alcoholic cirrhotic. These are potential, somebody who's in that situation is a potential transplant candidate. If you have a child C, you go in for a bridge procedure with either tips or banding, and if necessary, sclerotherapy. Gradually, the reason I told you, the reason that sclerotherapy is going out of fashion. It's a bridge to transplant. If you have a child C, this patient deserves a transplant. You have a patient with a child A or B with symptomatic stable disease. There are two situations. You have accessible varices. You have poor access. Somebody has done a sclerotherapy. It's the esophagus is narrowed. I had the very unfortunate episode of having to manage a person with a very narrow esophagus because the injection was given circularly, not in a spiral fashion. Or the patient has gastric varices, and gastric varices can't be banded. Sclerotherapy doesn't work. You have to use cyanoacrylate glue, and that's the sort of treatment that you do for gastric varices. So if you have a poor access or gastric varices, you do a selective shunt. Okay. If it's accessible, you would treat that with banding and sclerotherapy. If it fails and the patient has a progressive liver disease, it proceeds on for transplant. If there's a stable disease, you may choose to go in for a selective shunt. So please take a screenshot of this, and please take a screenshot of the next slide also. So this is for a non-alcoholic and an abstinent alcoholic cirrhotic. Child C, child A, okay? Non-cirrhotic, active alcoholic, elderly with poor Karnofsky. If the patient is compliant with good access to the varices, go in for a banding or a sclerotherapy. If it fails, then you decide on whether the patient is a poor operative risk or a good operative risk. Again, if the patient is non-compliant, not willing to give up his drinks, or his vessels, his varices have a poor access, or he has gastric varices, again, assess this patient whether he's a poor operative risk or a good operative risk. Has a poor operative risk, you go in for tips. If the patient has a good operative risk, if he has a good ascites and a good anatomy. Good ascites means that the ascites is responding to your diuretic treatment, has a good anatomy, stable anatomy, no extra mucosal, extra portal, prehepatic thrombosis. You go in for a selective shunt operation. Intractable ascites, where the ascites is difficult to control, you go in for a non-selective shunt, either a portocaval or you can go in for a mesenterical caval shunt. If, however, the patient has a splanchnic venous thrombosis, you go in for a devascularization. Okay, chaps, so that's my last slide. Open for any questions if you have any. I know it's a difficult topic, and I've tried to make it as simple as possible. I'm glad you asked the question, which is selective, which is non-selective. We had a very extensive discussion about which is selective, which is non-selective. And with the X shunt, I hope I've been able to convince you that the problem of a non-selective is that if you're diverting blood away from the liver, you have a liver atrophy, sometimes even liver failure if there's too much being trans, and you have a profound hepatic encephalopathy, particularly if the patient is used to having a high protein diet. Right, any questions?
Sir, the full form of TIPS is transjugular intrahepatic photosystemic shunt.
Yes, because we started off.
The name, why transjugular?
Because that's the easiest access. Why transjugular is because, think about it, I need to access the hepatic vein. Okay? Is that right? Isn't that right? I need to access the hepatic vein. Now, if I'm accessing the hepatic vein, let me just show you. That's the IVC. Hepatic vein comes off like that. Usually you have the middle and the left hepatic coming off like that. So if the angle is down below, isn't it easier to access it from the top, transjugular, rather than through the bottom? You can't do it from the transfemoral because you have to do a loop to access it. Get it?
Okay, sir.
So that is why transjugular. Okay, transjugular portosystemic shunt, intrahepatic portosystemic shunt. TIPS. When it was initially described, we used to call it TIPSS, but somebody's in the course of, whatever, in the course of age, we've dropped the last S. So it's now TIPS, TIPS, TIPS.
Sir, I have one question.
Yeah, sure.
Sir, you were telling about umbilical herniorrhaphy in a
Yeah.
patient with total hypertension.
Right.
Then, sir, as the skin is almost thinned out due to ascites, so was any difficulty on putting the mesh because the
No,
ascites will never
we
allow
didn't.
the wound to heal?
We didn't put in a mesh because that was, if that patient that you saw, the omentum had come out. The skin had broken down. So that was the omentum plugging up the thing. Otherwise, he was pouring out fluid. Get it? So it's open to the surface, so which means potentially it's infected, no?
Sir, means in that case, is any patient with a umbilical hernia with ascites, we will go for anatomical repair. Means after the reducing contents.
No, it depends.
Putting
If the
mesh.
patient doesn't have a leak, and you can keep the ascites under control with extensive treatment, and we've been through all the modes of treatment for medical treatment for ascites. If the patient responds to repair, low salt, salt restriction, diuretics, give spironolactone, and then add a loop diuretic, either furosemide or torsemide. And we've told you why we need to add the spironolactone and amiloride to the furosemide. Once you can keep that under control, you can actually go in for an extra peritoneal repair as well. Okay,
sir. Okay,
but this is the problem. The problem is some of these people present very in a poor situation like that, where ideally that particular patient would have preferred having a Levine shunt, but a Levine shunt is expensive. This particular patient that I showed you couldn't afford a Levine shunt, so we had to treat him with very aggressive diuretics to try and control his ascites in the post-op situation. One particular patient, he actually did something which was as an experimental procedure. we actually did, hang on, I think I've got the picture out here. But for heaven's sake, please don't. Can you see that? Can you see the screen?
Yes, sir.
What we actually did was a peritoneosaphenous shunt. Can you see that?
Vessel.
We made sure that there wasn't any reflux of blood up the down the which means the saphenofemoral junction was all right. So we anastomosed that to the Malgagnes bulging. That was an anastomosis out here. Unfortunately, that patient had a huge amount of circulatory overload, and I'm afraid didn't do too well. Okay. Any other questions, chat?
Sir, is selective shunt or partial shunt are same or different term?
No, it's a different term. When you say it's a